Good morning, everyone. Welcome to day 39 Eve. And with all the excitement that goes with it, I'll call the meeting of the Special Committee on Access to Quality Healthcare to order. I know we have some members that were going to join us online as well. We do have a quorum. We have one bill to consider today. It does have some sections in it. And to begin with, if I'll start, because there's one small section in section 1 that I'm probably most familiar. This is obviously a substitute to Senate Bill 82, which had been is in our committee, and but most of the language you'll see is new language. We're working off LC 339165 ERS. We'll make sure all the committee members have this, including Representative Fry is online. We'll make sure he has the updated LC number as well. So if we'll start, if you look just in section 1 down on lines 14 through 20, we obviously know we've been going through a public health emergency declared by the federal HHS due to the pandemic now for well over a year. We did do some protections for Georgians to try to make sure that during a public health emergency, they wouldn't also have the disruption of their providers changing abruptly, in particular in the middle of a planned year. The section, and that passed and was signed into law by the governor. Just a little clarification in section 1, just references the proper federal code that we were using to explain what a public health emergency, and in particular in House Bill 454, this is just a clarification of the language of public health emergency that is declared at the federal level. I'd be glad if anyone has any. I know we're going to go on in a minute to section 2. I didn't know if anybody signed up to speak particularly to that definition. If not, okay, then we'll go on to section 2. And if we could, Chairman Knight, if you will walk us through section 2. I know this committee has seen this language before, so we will start with a head start. And I know there may have been some clarifications or cleanup, and I appreciate you giving us information on section 2.
Okay, thank you, Mr. Chairman. This is the committee has heard this bill as 1519. It got in late to the process, even though this committee passed it out. There were some concerns with the bill. We've diligently worked with a number of members and others out there to address some of these concerns. But briefly, Senate Bill 82 or 1519 is addressing the issue of unilateral amendments. And what that is when patients receive their services at in-network hospitals or other healthcare facilities, they assume that the medically necessary support services are being provided as part of the main service: labs, lab tests, pharmacy services, diagnostic testing, and they assume that this is going to be in network. However, what we're finding, and it's been well documented, is the insurers have been implementing unilateral sort of site of service or designated provider programs, where after the fact that the Office of the Insurance Commissioner has approved these plans, they're then coming in and unilaterally making changes and deeming these support services as out of network and directing the beneficiaries to other providers outside of these facilities and making those in network. So that's what this bill does. We have addressed the issues of support services. I think the committee will remember we had called them ancillary services. There was some confusion with that. So we've heard that concern and just very specifically defined within this code section. They're called support services. So those have not changed. And then we've also heard concern from Kaiser because of their uniqueness in their healthcare model. We have carved them out of the bill. So there's one other change from that. We've added some dental language in from that area. Again, still same practices that we're finding, and we've added that part into the bill. So that is SB 82. Many of you will know this or have heard of this back in your districts, perhaps, is white. One of the main examples of this is white bagging, whereby the pharmacist within the hospital or the setting is not allowed to be used. It's considered out network. And then what is happening is that the insurers are demanding that, you go use a outside pharmacy. Again, I know we say that, but any number of specialty pharmacies, a good example is chemo for cancer. A patient goes into the hospital to get their chemo treatment, but yet their chemo drugs and infusion is delivered from an outside pharmacy that has nothing to do with the hospital. And there are a whole host of issues that are concerning there with the patient. And again, one last comment on this bill. These support items and when what is triggered is when they've got to have a trigger. And that trigger is when these unilateral changes are affecting the patient. Okay. And again, we've discussed this. The patient comes first. This is not about profit. This is about the patient. So, Mr. Chairman, that's the updated version of the bill. I'll be happy to take any questions.
Are there questions from committee members? Did we have anyone who signed up to speak specifically to this section of the bill? I know we took testimony on this, largely this similar language. When we heard it the first time, and I think testimony from hospitals and insurers, I believe. All right, if not, we'll proceed with section 3 of the bill. And I'm going to recognize Chairman Rhodes, if you can come get us started on that. This is a section that's also dealing with health and healthcare. I do know one of the problems, as a little background, and I know we've discussed, was even during the pandemic, a problem with clinical lab work for Georgians being sent to North Carolina, to Arizona as the closest place. And I do believe some of this language was created in an effort to encourage Georgia-based labs. Obviously, we hope that there's never another pandemic, but certainly if one of our family members has an illness, or it's pretty much just as important as a pandemic of getting accurate lab results back promptly and efficiently, and not being required to truck or fly across the United States. And maybe there's a way to encourage clinical labs to provide services for patients, for Georgia patients in Georgia. Is that, and you can go ahead and start there.
I'm a little out of my wheelhouse talking on insurance. I usually feel better talking about raccoons and possums. But yes, and I want to thank Chairman Knight and Chairman Newton we've had multiple conversations on this matter. And basically what this is, we've got 6 or 7 clinical laboratories that we have in the state of Georgia that basically are in areas of our state that we needed. I'm talking about 50 some odd counties that LabCorp and Quest do not have a presence in, that these labs can get the work and get the specimens, get it turned back around and get it back to our citizens much quicker than it's being done. And basically they're not asking for, everything. They just want to be in network so they can do this for our citizens of our state. One thing that help keep more business in the state of Georgia, and they're not asking for the moon. They're willing to accept exactly what LabCorp and Quest get on those type payments. So basically that's what it does. And we've got the lab that's in my neck of the woods, and a friend of mine, Randy Peters, is online if anybody has any questions or needs more explanation. But basically between what I just said and what Chairman Newton said, that's pretty much this section in a nutshell.
All right. I'll recognize Randy Peters, I believe. Is that's who's online to speak with us. Go ahead, Mr. Peters. We can't hear you just yet.
Can you hear me, Mr. Chairman? Mr. Chairman?
We're trying to try again, Mr. Peters.
Can you hear me, Mr. Newton?
We do, yes.
Okay. Thank you so much.
If you can introduce yourself and proceed.
Yes, sir. My name is Randy Peters, and I am an owner and CEO of a reference laboratory located in Milledgeville, Georgia. We currently service around 30,000 patients a month and employ over about 200 employees. Most of our, I would say probably 95% of all of our services are located in the state of Georgia. Our main laboratory where we run all the specimens is located centrally in the state. And we are just trying to provide, customer care to all citizens throughout the state of Georgia. Currently, as it sits, there are 141 counties in the state that are underserved out of 159 counties total. And we have plenty of access in a lot of these rural areas. A lot of patients during the pandemic were calling our laboratory to have access to our services, but were being turned away and told that their insurance provider would only pay for in-network services, which is through LabCorp and Quest. And we had a significant advantage being located in the state due to the fact that we could turnaround time with some of these specimens in less than 24 hours, where, in the height of the pandemic, LabCorp and Quest was taking around 13 to 14 days to get results back. And Mr. Chairman, this doesn't stop with just, COVID-19. This is access to critical care for, blood testing, toxicology testing, et cetera, to all the citizens of the state. And like Mr. Rhodes said, all we're trying to do, this would not increase healthcare costs, because all we're asking is for the same reimbursements and access as LabCorp and Quest, which is preferred laboratories through these insurance plans.
Thank you. And thank you for being concise, recognizing our time. I appreciate that. Appreciate the work you guys do in Georgia. Is that someone? Oh, Chairman Knight.
To my friend, Chairman Rhodes, and to the constituent who I've met with, this is a big deal. And this goes back to access in Georgia of all healthcare providers, and access, is very important to the patient, especially in our rural areas. I do have a concern because I want to make sure that we're going in that direction. The question as I read this bill is it's calling for 50 miles or 1 hour, but as I understand it, the contracts with the state call for much tighter restrictions. In other words, or tighter distances. Urban is usually around 8 to 10 miles. Suburban is usually around 15 to 16 miles, and rural is 24 miles as far as a radius. I think we need to pay attention to this, because as I read it, I may look at for some help from some of our members who are much more apt than I am in this. But as I read this, this may actually go against or be pushing away. We may need to tighten what's in code, because if or what's in this bill, because if this bill becomes law, it will supersede, I think, the contracts, or it will limit the state to its ability in its contracts to put it at 50 miles if we codify that. So that's why I'm having, I may, counsel, is that
Ledge
am I
counsel
reading this
question
correctly?
and I don't know if anyone from SHBP is here, but if you say would a tighter requirement still be allowed if the maximum was 50 miles, but they could still continue with their tighter urban locations, right?
I'd say 25 miles, then they're still in compliance
within
with this
50.
code section. And it talks about contracts entered into for state health benefit plan after July 1, 2022. So it wouldn't impair any current contracts in existence. So
Mr. Chairman, and again, maybe if I follow up, I am concerned though, if we codify this at 50 miles, and our problem is we're trying to make sure that we have access, more access, especially in our rural areas, that at the next contractual negotiations, if the code says this, okay, while it may not prevent it from being implemented at shorter distances, it certainly though would give somebody could interpret this bill as giving legislative intent that it should be actually 50 miles versus what I think the intent of the author is closer. Am I?
Mr. Chairman, I'm fine. Let's tighten it up.
Would you, I mean, since what was the maximum on the range you said that's current? Was it 25 or 24 miles?
My understanding, and this varies depending on the insurance company that, the plan, but urban is typically one lab within 10 miles, suburban 15 miles, rural 30 miles. That's for one plan. The other plan is 2 labs within 8-mile radius. Suburban is 2 labs within a 16-mile radius, and rural is 2 labs within a 24-mile radius. That's what I understand is the current state health benefit in the current state health benefit plan contract.
Representative Perkle.
Thank you, Mr. Chairman. And to the chairman's point, I agree with the backbone, the intent of what he's trying to get at. But honestly, in some of our districts, it takes 25 miles to get to the grocery store. And I'm afraid if we tightened up excessively, then we might have compliance issues with this. And just speaking for me, I'm fine with the 50 that we have currently here.
Representative Bentley.
Yes, sir. Thank you, Mr. Chairman. I just need someone to kind of help me better understand. I live in Taylor County. America's has a hospital, and that's about 35 minutes away from where I live. Upson County has a hospital. That's another 30 minutes. Then, of course, there's Peach County. That's a little less than 30 minutes. So can someone kind of help me understand exactly how this bill, the language in this bill about the 50-mile radius and all of that what does it really mean for people like myself living in very rural Taylor County, Georgia?
Is there, I don't know if Mr. Peters online or if anyone in the audience is able to speak to that question.
You there, Randy?
Yes. Thank you, Mr. Chairman. Right now, the gaps in the rural areas across the state, they vary. But like, for example, a lot of these hospitals are facing closures, serving some of the most at-risk communities. For example, Wheeler County, where the Lower Oconee Community Hospital closed, around 25% of those residents, lost access to care, and over 40% of those children there live in poverty. With that hospital closing, those residents will now have to travel excessive over 30 miles to their nearest emergency care provider. This is happening across the state more frequently than I was aware. And there's a lot of data that supports this. So I think by having more access to these labs in these counties across the state, it would prevent a lot of these patients from driving longer areas. For example, I had a family, during the COVID crisis that drove 72 miles to come get a COVID test because they were constantly being turned away from other areas, but there was no sites even close to them. Even today, we still have the same issues with blood testing, toxicology testing, et cetera. So it's pretty common across the state once you get below, Macon, Georgia, let's say. And I would definitely encourage to Google the testing sites for LabCorp and Quest across the state of Georgia. I was very surprised that when you look at the draw sites across the state, they're very limited, especially when you get below Macon, Georgia. And that's from Columbus across to Savannah, down to Bainbridge, and even Blackshear, which is Waycross.
Thank you,
But-
sir.
But a short answer,
Yes, sir.
Representative Bentley, would be if your doctor could get possibly your lab work to one of these type labs, and you could get it back quicker than it
Located in Georgia.
correct
that what your point
located
is?
in Georgia, then you having to send it out somewhere else and wait on that time.
Gotcha. Thank
And-
you.
Can I add one more thing, Mr. Chairman?
Go
If
ahead.
you're quick,
I'll be quick, I promise. So a lot of hospitals too, they do stat labs, and they're not reference laboratories. And one big difference is we are a reference laboratory and offer, up to 200 different types of blood testing, where a hospital sends their testing out to reference labs like ours. So you'd have direct access to the reference lab versus it being sent out. Thank you.
And they are located in Milledgeville?
Yes, ma'am.
And
they have multiple
in
sites.
particular, I guess we see that in 109 through 111, contract with a qualified clinical laboratory at in-network rates. That's the point you made about not wanting a rate different than, it doesn't preclude any carrier from still having a nationwide contract or anything else. It just would add that the same rate, Chairman Rhodes, would go to
Correct.
the qualified clinical laboratory within the state, I believe. Chairman Parrish.
Mr. Chairman, help me understand something here. I like the idea that we're going to try to do business with local folks who are here in the state and create jobs here in the state and this sort of thing. But exactly what is the problem we're trying to fix here? Because as I understand it from reading this first time through, it sounds like all the labs have to be able to do the same test. So what is it we're trying to fix?
They do, but these Georgia labs are a lot more prominent in some places, especially in rural Georgia, 50 some odd counties, that we do not have a presence of LabCorp and Quest. Basically quicker access and better access for our citizens to get quicker turnarounds.
And it says here that lab would be within 1 hour or 50 miles of the plan member's place of business or residence. We're not talking about the hospital. We're talking about the plan member's residence. Is that correct?
We're talking about the patient. The patient.
Yeah, but the lab isn't going to come to the patient's home.
Actually,
No, but I'm saying within an hour of them.
I want to try to help you get to where you're going, but I need to
Okay.
know what we're trying to fix.
Well, I was okay. Well, I was wondering why you who know all about this are asking me a question.
I believe there's a problem that these Georgia labs are being left out of network, even though they're willing to accept the same rates as a national lab that sends our specimens out of state to be processed. This just would encourage state or require state health benefits to also, it's the same in-network rate to contract with a qualified Georgia lab that would offer in these areas, I guess these 50 counties and other areas that you're talking about would offer services at a Georgia-based lab in addition, not instead of, but in addition to.
It would just be another option.
a large.
I don't have a problem with somebody being a willing provider, and that's what we're talking about.
think
If they're
that's
willing to provide at the same rate, I don't understand why we can't do that, but I'm just concerned about, are we fixing a problem or are we creating a problem?
Well, I think this gives our doctors and our citizens more access and quicker service than sending stuff out of state.
Hang on just a second. I think, if you don't mind, Representative Prince.
Thank you, Mr. Chairman. I think that conversation may have cleared it up, but just see if I can put it in basic terms. Basically, we're trying to get more laboratories into the network.
We're trying to open some
We're trying to-
avenues for our citizens that we don't currently
Again,
have.
getting them on basically in the network so that they
Correct.
have more access.
Yes, sir.
Thank you.
Chairman Knight.
And again, I want to make sure I'm clarifying because I'm trying to help. I agree with you on the access and quite frankly, to allow providers, any willing provider to serve, especially if they're Georgians and there's processing here. But I want to make sure I understand something. There's two spaces in lab. There's the place where it's drawn. In other words, we as a patient, for instance, goes and gets the lab work done or drawn. But there's also processing. And so there's two sides to the, or there's two components to this, and one is the processing. Okay. So I want to make sure that we're clear on that, because I agree with you. If you got to send a lab out of state and transport it a long ways, I think there's issues there. But that's what I'm trying to figure out is the draw. Okay. Is that where we're going with this? Is that 50 miles within a patient's home that's here? Because I'm because I want to help the situation, and I want as many providers, especially local providers, physicians, lab nurses, pharmacists as we can get, because I believe the more providers in healthcare that we have closer to our patients, our rural areas, is what this General Assembly has been very much working to. Okay, I want to be very clear about that. But I'm also trying to figure out how this part, I'm not sure this does what we think it does, because I do think it's a matter of, is it any willing provider? In other words, versus having one, because if there is one, how is this keeping, say, a local Georgia-based lab company, how is this helping them if they still cannot get into network? That's my
I believe your statement is probably your description of what would be called any willing provider. It's any willing Georgia-based clinical lab provider at the in-network rates will be contracted with. And that doesn't mean the lab is within, the actual lab is necessarily there. It has to be in Georgia, but it can be lab drawing facilities that are that are closer to the patient. And like you say, they're probably likely to be much closer than this minimum, but I think it is a willing provider in Georgia will accept the same national rates that are offered, that SHBP will contract with them and offer that option to Georgia patients. That's my understanding of, I believe, the goal and the effect of the bill, in particular, that's lines 109 through 111. Chairman Perkle.
Thank you, Mr. Chairman. So one of the things that we've looked at for some time in this committee is access to healthcare that can provide bang for buck for the consumer, where the consumer comes out ahead, patient safety and consumer rights. If you go back to your days in economics, when you can increase the supply of these labs, when you add additional supply and you shift that supply curve out to the right, you will see price go down. And so at the appropriate moment, I'd not make a motion, Mr. Chairman.
Thank you. Not quite at that moment, Representative Prince, and then we needed to see if anyone had, I know there was a new bill coming out. I need to see if the people who signed up are interested in speaking. Representative Prince.
Thank you. And just going back to Chairman Knight's comments, just for clarification, the lab is what we're talking about, that does the actual processing, not the, okay, I can come in, get my blood drawn, and then it's shipped off somewhere. You're talking about the lab itself that does the testing, or are we talking about, I mean, patient services versus.
My understanding is it includes providing the laboratory services, but not that just that the lab, it's the official lab is really in one place in Georgia.
It's
They do
Georgia
have-
labs that are licensed in that code section. My understanding.
So we're talking the lab itself, not drawn.
You're talking about the 50-mile,
Right, exactly. the 50
target,
mile target. 'Cause that's,
my understanding had been that they would provide lab services within the 50 miles, which does
Correct.
not mean the actual.
Right,
Not
so it
just
could
the
go
lab.
out
The
for
lab would be
testing
in
and come
Georgia, but the lab
Services,
drawing
not the
ability might
building
be.
itself, but services in
Right.
that area.
services. Thank you.
All right, so let's see, Anna Adams, do you want to speak to any portion of the bill? If you can come on up and introduce yourself.
Thank you, Mr. Chairman. Anna Adams with the Georgia Hospital Association. I wanted to offer our support for the second section of this bill dealing with unilateral plan amendments. This is an issue that our hospital members have been experiencing for a while, but it has certainly increased over the last several years. And we want to ensure that patients who visit our facilities thinking that we are in network, who understood what was included in their plan, can bank on those services continuing to be included throughout the duration of their plan. So we appreciate your consideration of this measure, and I'm happy to answer any questions.
Thank you. I'm looking at lines 59 through 62. So you're saying the hospitals appreciate the change that there would not be in the middle of a contract, a unilateral change or unilateral amendment. But obviously, whenever contract renewal comes up, those are not amendments or changes. Those are bilateral talks. And
That
all.
is correct.
Okay.
And I think that's an important point of clarification because when we talk about white bagging in particular, which is the utilization of a pharmacy service outside of the administering outpatient infusion center, for example, if upon the entrance to the contract, both parties agree that the pharmacy on site would not be used, that's absolutely appropriate. But once the contract has been signed, we don't want anybody coming in and making changes to that. So those patients no longer have access to a service that they thought was available when they signed up for their plan.
Thank you. I believe Representative Fry, if you're online, did you have a question for this presenter? I'm sorry.
Yes, thank you, Mr. Chair. I just wanted to kind of clear up, ask a question to kind of clear up what I'm thinking about on this 50-mile radius. Is this part of the bill just saying that the state health benefit plan has to ensure that our insured have a lab service within 50 miles of their residence? That's
At a
all.
minimum of 50 miles, correct?
That's all it's saying, right? So they can pay in-network prices, even if it's not one of the big lab companies. That's
Right. It would
literally
also
what we're
apply
doing.
to a Georgia-based lab that's not one of the two that have been mentioned. Correct.
Yeah, this is great. Thank you for the clarification. This is a good bill. Thank you.
Thank you, Representative. Any other questions for Anna? Thank you, Ms. Adams. Now, Wes, come on up, just introduce yourself for the committee and proceed.
Yes, sir. Morning, Mr. Chairman, committee members. Weston Burleson with the Insurance Commissioner's Office. We're not here to take a specific stance on the bill. We did want to touch on one area that has come up a few times around white bagging, and just want to publicly let the committee know that we're committed to looking at some stuff we can do internally, regulatorily, that without legislation to address this issue. Had a few conversations with very early conversations with the Georgia Hospital Association about this. I know it's an issue that's impacting them. We've also got a letter from the Rural Caucus that this is an important issue for them. And so we just want to publicly say we're working on this, and be glad to have some additional conversations. I have Greg Conley with me, who's our executive counsel. If y'all have any specifics, he's going to be the one leading the charge for the agency.
Thank you for your attention to that and your department and your commissioner. Chairman Knight.
I appreciate y'all, being here, but, the question arises is that it's well documented that these issues have been brought to your office for quite a while now. And you say you have the ability to take care of them, but you haven't. This has been going on for well over a year. I know last year about this time, the rural hospitals were cringing at what was going on with white bagging. I know that y'all have received numerous documentation in the form of requests and letters with examples of this. So again, is this a matter of you've chosen not to address the issue? Or is it a matter of you don't think you have the ability to address the issue?
And you're not, to be correct, you're not opposing this bill by saying that you're interested in working on it.
No, sir.
Yeah.
No,
Go
we,
ahead with
and
this.
I can let Greg weigh in a little more. I know he's, a lot of those complaints do filter down to him. And we have been taking a look at it. It has been something that's come in for a while. And, we've been taking some steps and we just want to let you all know that, we're really looking at this seriously and we want to take some actions, and we'd be glad to have a conversation with any member of the committee on specifics.
And no opposition to the legislature's involvement as well.
No,
right?
sir. We just want to
Thanks.
publicly let you know that, we're aware and we've got to work with you.
Any other? All right. Thank you.
Yeah, thank you.
Jesse Wethington.
Thank you, Mr. Chairman, members of the committee. My name is Jesse Wethington. I'm the president and CEO of the Georgia Association of Health Plans. Appreciate the opportunity to speak with you this morning about a couple of issues my members have with this bill. Nothing more fun than talking about a substitute that has a couple of things in it that we didn't have an opportunity to really look at, but just kind of generically on section 1, just to make a suggestion, this is not really a position, but in terms of the public health emergency, obviously House Bill 454 was something that was passed and signed into law last year. Additionally, the legislature passed some additional specific codification around the difference between what did and did not constitute a public health emergency. I would suggest to you that since that is something that you all tightened up last year in terms of defining the state public health emergency versus a federal public health emergency, the governor particularly did end that on June 30th, 2021 last year. And that's something that you all have gone into code and say it must be sustained by the General Assembly's action if there's going to be such an exigent circumstance. So my suggestion would be that do not cede your power and the governor's authority here to the federal government's determination of what constitutes a public health emergency, but rather redefine that as a declared state public health emergency because we're talking about state law. To continue into part 2, House Bill 1519, just to clarify, we did not have the opportunity to give testimony on that when it was heard first in this committee earlier in the year. I appreciate having that opportunity now. My members have several concerns with that bill, particularly, there are issues around white bagging, which we think that there are legitimate discussions to be had. I think that the regulatory process probably is a better venue for that than a substitute bill that's appearing before day 39 that we've not really had the opportunity to vet. But white bagging aside, the bill does many, many more things than that. It is very, very broad in its scope in terms of what is impacted here. And so if you want to address white bagging, section 2 of this bill is a broadsword where a scalpel would be more appropriate. And a lot of those issues are around the affordability and the cost to our plan members when they are dispensed a drug in an institutional setting versus our ability to even let them know that there's an opportunity to have the same drug provided to them at maybe a fifth of the cost in a different setting or a different distribution channel, be it a specialty pharmacy or a local community or independent pharmacy. This would severely hamper our ability to do that. An additional impact would be that there are many multi-year or evergreen contracts that our members enter into with healthcare providers of different sizes and shapes. What this bill would do is create a very, very strong incentive for that practice to be abandoned and for these network provider agreements to have shorter terms than many of them currently do. Again, speaking of 454, that was an issue that the General Assembly took around when there's disputes with hospitals and insurance carriers about large hospital systems going out of network. That would be a more frequent occurrence under section 2 if this bill were to pass, because the duration of a lot of these network provider agreements would necessarily be shortened to give us the ability to enter into those negotiations on a more periodic basis. Additionally, if there's no consideration on the other side of the equation. For example, if a hospital system were to buy up an outpatient imaging facility, it suddenly becomes an inpatient imaging facility. The cost of an MRI trebles overnight, same machine, same technician, there's a different brass plate on the door. Our members are now roped into that with no ability for us to even nearly suggest that there's an alternative for them to go down the road in some instances. And additionally, a lot of these so-called unilateral changes are rights that have been reserved in the initial contract negotiation and have been agreed to by the parties. So again, this is a bill that is very, very broadly written. Its application goes into a whole host of things beyond mere white bagging. And so we would urge you to think about potential unintended consequences that could result from Section 2. Moving into Section 3, if I could ask a clarifying question, I believe that only pertains to public or state healthcare plans. Am I correct?
Correct.
In terms of the presentation or how the bill was presented, there, as Chairman Knight observed, there are currently more stringent network adequacy agreements in those public contracts than would be contemplated under the bill. So given that the plan administrators that are currently servicing state health benefit plan members or on these public plans are currently subject to more stringent requirements than are considered under the bill, under longstanding contracts, yet we're still presented with this access issue. I don't know that we've definitively been showed that state employees do have an access issue. I think this may be more about a contracting issue with certain particular providers and certain plan administrators. Additionally, there is a Fiscal Note Act and a specific state health benefit plan Fiscal Note Act. So we would appreciate the committee would at least follow the letter of the law in terms of that, or have the committee or the chairman make a determination that there would not be a fiscal impact on either the state budget or the plan dollars and premiums of state employees that would be affected by a bill. Of course, the state health benefit plan is funded through premium dollars and contributions by public employees, as well as the different entities that employ those folks. So again, I think there's some potential issues with how that bill is drafted. There could be some compliance or regulatory problems. Again, is it the patient's home? Is it the patient's place of business? We would like to see some additional evidence around the actual lack of access to this. Show us a heat map where there is a gap here, because nobody has shown that there's been a corrective action plan or contractual issue in terms of the more stringent contractual requirements that the plan administrators are currently held to. So for those reasons, we would urge you to hold action on these bills. We think they need a little bit more work.
Chairman Knight.
My friend, I'm curious because I'm not sure that this bill does what you said it did. You gave examples about changes in provider location or services. My understanding is that this bill has nothing to do with that, nor would those instances would trigger, an allowance for a plan amendment. So what this bill actually does not speak to a change of that nature. So I'm curious if you've read this bill or interpreted it that way, because it does not do what the example that you just did or just gave to the committee.
No.
Second of all, you talk about choice. So right now there is no choice. There are unilateral plan amendments that give no one choice, not the patient, not the provider, no one choice. It is a unilateral plan amendment that is being, quite frankly, we can go through provisions if you want and examples, but they're unilateral plan amendments that you guys are coming up after you've been approved by the OCI. And then you're implementing these unilateral plan amendments in which, these supplemental services are available, but then after the fact, you're unilaterally taking them out. So from a patient's perspective or a beneficiary's perspective, there is no choice. It is a unilateral, not only amendment to the contract that affects the provider, but it also affects the beneficiary. I've heard this argument as we've debated this bill, as I've tried to understand concerns. So isn't it true that under the current practices that we see, this unilateral amendment practices that we're currently debating and trying to fix, isn't it true that there is no choice? There's not a choice to remain or to use that provider that was in network as the plan started. It's use one provider, and that's the one that we, as the insurance companies, say to use, or otherwise it will be considered out of network. Isn't that true?
So the chairman's first question, I believe that this is, section 2 is still the underlying bill with a few changes. I've not had the benefit of seeing the substitute. So I have to disagree with your assertion. The patient still does have a choice to access the drug, not at the in-network rate necessarily, or if they have the ability to go get the same drug distributed from a pharmacy down the street or sent to their home if they want to do that. What we would like to do is preserve their choice not to have to pay a 500% markup on the same drug if they do not wish to. I haven't had the benefit of seeing the examples that you're talking about, so I don't want to comment on something that I haven't seen. You and I have not had a conversation about this bill. But again, it is very, very broad in its application, and what this would be ensnared in the net of section 2 goes far beyond mere white bagging.
Just a follow-up to my friend. But you talk about choice, the patient has choice. No, the patient had a choice when they entered the plan, knowing what was in network and what of these supplemental services that were associated with a major procedure would be, and that those were inpatient procedures that would be, or in network, should I say, procedures that would be covered. But in fact, I don't think that is much of a choice, that when you later on unilaterally change the contract and thus now outline these supplemental procedures and services as out of network, there really is no choice other than the patient, paying an out of network rate or cost determined by the insurance companies. When in fact, when they entered into the plan, those services were indeed part of the plan and was sold as such under the plan. It's sort of a bait and switch, if you will.
Well, again, to the chairman's point, and again, I have not seen the examples that you're talking about. There's a whole host of practices and particular situations that would be ensnared under section 2 of the bill. I believe that you're being genuine in some of the examples that you're laying out. There are other examples where the mere fact of us notifying the patient that they have another option would be one of the things that would be prohibited under section 2 of the bill. We want to preserve our ability to continue to get the best deal for the patient that doesn't harm their quality of care or their access to a similar or efficacious or therapeutically equivalent treatment, drug, treatment modality, or therapy. This should still be handled where it is today in the private sphere, where these can be negotiated on a case-by-case basis with providers. There's wide variety in terms of how these are negotiated, from a sophisticated hospital system to where they're going to go in and look at every clause that's in one of these contracts aggressively, to more generic contracts that smaller providers have. But you're casting a very, very wide net with section 2, and we would caution you against that and say, if you want to address white bagging in particular, that's a conversation we're willing to have. We think that should be done in a regulatory process, but section 2 is not it. White bagging is in it, but it's one of a whole host of things and potentially negative unintended consequences that I don't think that the committee would be happy with were they to come to pass.
Is there now, as far as what you mentioned, as far as a contractual arrangement that already allows something in your contract, that would not probably qualify as a unilateral amendment. If you already discussed it in advance at contract renewal, at the most recent contract signed, that would not be a unilateral contract amendment that's prohibited by this measure in section 2. That would just be something that's in the contract that you're enforcing. You would agree that you should not do a unilateral amendment or a unilateral change during the middle of a contract, and also during a patient's contract year where they relied on your in-network assertion for a hospital or health system.
Well, I think there's a difference between reserving the right to take an action during the contract term versus a unilateral change. I'm not an attorney, so I don't want to get on firm ground here. But again, and this bill wouldn't impair current contracts, but this would significantly alter the landscape going forward for when we do get into a renegotiation period with a provider. Knowing that this is out there, I would anticipate that trying to get the best deal for the organizations that are on the other side of this, that they would be a little bit more aggressive about some of the particulars of this, knowing that they were underpinned by the statute.
And that way the hospital would know in advance what was and what wasn't going to be requested regarding whether white bagging and medicines being brought in from outside or
I
being
suggest you
directed.
have a very different negotiated environment should this bill pass than what we've had to in the past.
Representative Bentley.
Yes, sir. Thank you, Mr. Chairman, and thank you for your comments this morning. And as a legislator, rural Georgia legislator that truly believes in patients first, can you explain to me what you are suggesting to this committee? How is it going to truly impact the patient?
So we would say that, we are, as insurance companies, we are trying to both get a measure of access, affordability, and quality for our membership. And there's a balance to be struck there. Oftentimes the balance is not something that the provider community agrees with is an appropriate balance. And we're going to continue to disagree about that. The issue is when those disputes spill over into the legislative arena, and our ability uniquely by this bill would be impaired to contract without any consideration on the other side for unilateral changes, purchasing different provider groups, taking them in network, or taking them into the aegis of a hospital or larger system, which does and has been demonstrated to negatively impact patients in terms of their affordability, or restricting their choice to go outside, get the treatment modality at a cheaper, more convenient location for that patient. So there's a balance to be struck here, and I would just suggest that this bill does not do that, ma'am.
Thank you.
Thank you, ma'am. Representative Perkle.
At the proper time, Mr. Chairman, I'd like to make a recommendation to do pass.
We'll take that recommend. Apologize. Thank you, sir.
Thank you, Chairman.
Michael Power, did you want to speak on this bill?
Sure, I'll be brief.
Thank you. Please do. I apologize.
Keep it brief. Mr. Chairman, members of the committee, Michael Power with the Pharmaceutical Care Management Association. Sorry, my allergies are killing me. So if I sound congested, it's just allergies. We weren't able to see the new substitute prior to the hearing. So I think our focus and our comments do focus on section 2 of the bill, particularly the provisions related to white bagging. This is an issue that is sort of gaining attention across the country. A couple of things we wanted to point out. We would agree that this issue probably needs more time and consideration. We think an interim study would probably be best, and this issue be handled through the regulatory process. It's important to note that specialty pharmacies are accredited and credentialed by a national organization, a third-party entity called URAC. And URAC is the organization that goes into these pharmacies and determines whether they can handle not only the drugs, but also the education that is needed for the patients to take these drugs. And so they accredit and credential specialty pharmacies, right? Every year they do a report. Their most recent report on the results of these specialty pharmacies and how drugs are dispensed and their use came out. It's a 2020 report, but they show that drugs are dispensed, the dispensing accuracy is 99.98% through the specialty pharmacies today, and the distribution accuracy is 99.96%. So we're sort of chasing after an issue here that is actually working pretty good, not perfect, but pretty good.
And are you saying these are situations where a plan in the middle of a contract would all of a sudden say that you need to obtain your medicine from someplace other than the hospital pharmacy, but then that hospital personnel would put it in an IV line and give it to the patient?
I mean, I would need to see a specific example where that's been requested. We do know that a number of hospitals, roughly 40 to 50% of hospitals in their policies do say that drugs can't come through the white bagging process.
They do or say in their can or cannot.
They prohibit white bagging in their policies. And so we don't know if that plan, if that change occurred middle of the plan year or after that, when that contract was already in place. But we do know that some of these hospitals, roughly 40 to 50%, put that in their policy, that drugs can only be dispensed from their pharmacy.
Can you take a couple of questions? Sure. Representative Bentley.
I really don't have a question, Mr. Chairman. I appreciate his comments, and I'm ready to second the motion that's already been placed on the table.
I will call on you for that in just a minute, ma'am.
Thank you.
Chairman Parrish. Mr. Chairman, is there anybody else here that's going to talk to us about section 3 to help us clear up some of the questions about that?
I believe the testimony online and from the presenter is our situation now. We have reviewed this language with SHBP, and they have clarified that their current contracts that they send out are tighter than this, but that this would not require them to loosen them.
So
as far as the 50-mile direction, as far as the willing provider within Georgia at the same rate that's being paid in network in the current, they've not expressed an opinion on to me.
So I think what I'm hearing you say is SHBP is fine with this.
Well, I can't go that far. It's been presented to SHPP. We have not received any negative comments other than the fact that I think they clarified that their current contracts are actually tighter than this. So this would not require them to loosen them, and it would not impair any of the current contracting because
Well,
that's
I'm all about trying to help with this any willing provider. I think that's what we ought to be doing, but I have some concerns about what we're doing with this 50 miles in here. And I'm wondering if we're creating a problem rather than solving a problem with that part. The rest of it, I'm fine with.
Well, we will have a moment after motion and a second to offer amendments. If you'd like to leave out a line, and you might consider it a friendly amendment. Chairman Knight. Did you still have a question or a comment, or were you ready to get a motion?
Well, I guess a comment to the last speaker. You know, we talk about some of these standards, but the last time I remember, we codified that the standards of pharmacy were set by the state and not by outside accreditation agencies. So I want to bring that to the last presenter's attention. That's codified. And if you're requiring folks to meet standards that are above the state law, and where we've stated that those standards cannot go against or be higher than what the State Board of Pharmacy is, we need to maybe discuss those issues. And as far as safety issues, we know there are safety issues regarding this. Speaking directly to the other issues, white bagging is just a perfect example of what many have experienced in rural Georgia. But it goes beyond that. It goes to lab space, it goes to imaging, and it goes to a lot of those support services that the members depend on, that are part of and are integral to major healthcare procedures. And so you may even have a patient that needs lab work, it needs imaging, okay? It needs pharmacy to deal with healthcare matters. But now what's happening with these contracts and these unilateral amendments, people think that their hospitals or providers, even other healthcare providers outside of hospitals are able to go and the patient can get continuity of care, but they're not. So now they're being sent somewhere else to get their lab work. Now they're being sent somewhere else to get an X-ray. Okay. And then their drugs are being shipped in. So this is about the patient. It's about continuity of care. And then any of the issues in regarding choice, I quite frankly want to make sure that this committee understands this and that the folks that are listening to this, there is no choice. And that's the problem, is that the very people who are writing the plans, the only choice you have is their choice. And it's about them. Because if there were choice, we wouldn't be here. We would not be here. And when we have choice, and we have any willing provider, and we have people out there, the market is a free market and we'll drive down prices. But what you're going to find is that these contracts are with affiliated companies, or there's contracts that have financial incentives back to the insurance companies. So
Thank you, Chairman. If you don't mind, I got another member who'd like to speak. Chairman Nix.
I just like to say, I think we've had enough lectures. Let's either vote on this thing, table it, or leave. This is,
Yes, sir.
we're not, is anybody here gaining anything out of all this?
We're about ready for let me go back to you, Chairman Perkle. Did you have a motion?
Yes.
If you don't mind redoing
to
your motion.
pass.
Do pass. And Representative Bentley.
I second.
Thank you. Have a motion and a second. Is there any further discussion or amendments?
I'd like to make a substitute motion, Mr. Chairman.
A substitute motion or an amendment?
Well, we'll do an amendment. That's fine.
All right.
I'd like for us to remove section 3 entirely and renumber the bill accordingly.
All right. We have a motion to amend the bill by removing section 3. Is there a second? We have a second. Is there any further discussion about the proposed amendment? No discussion. If not, all in favor of the amendment to remove the entirety of section 3 from the bill, raise your right hand. All opposed to amending the bill? Oh, wait, I'm sorry. I may not vote. Representative Fry, let me see. We have 3-3. Let me find out where Representative Fry is on the amendment to remove the entirety of the lab section, section 3.
No.
Okay. The amendment fails. We're back to the original bill as presented. We have a motion and a due pass. If no further discussion, all in favor of the passage of LC 339165 ERS, raise your right hand. All opposed? All right, the bill passes. Thank you for your participation. Thank you, committee. We're adjourned. Am I good?